Madam President, I want to tell my colleagues here in the United States Senate about a bill I'm introducing called the Rural Emergency Acute Care Hospital Act. And for purposes of shortening the name of that legislation, it has the acronym REACH, R-E-A-C-H, so I'm going to refer to it as the REACH Act. Since January 2010, 55 rural hospitals have closed their doors. So you can see in the years that we have listed here, it adds up to 55 hospitals. Now, even more troubling is that the pace of rural hospital closures appear to be accelerating. Again, as you can see in the chart, the number of hospital closures has increased very definitely over the last 5 years. These closures are creating a healthcare crisis for hundreds of thousands of Americans across the country. The REACH Act will create a new rural hospital model under Medicare that will enable struggling rural hospitals to keep their doors open and maintain the most critical hospital service, emergency medicine. When a rural hospital closes, the community loses the life-saving capability of the emergency room. According to the National Conference on State Legislatures, 60% of trauma deaths in the United States occur in rural areas. After a traumatic event, access to an emergency room within 1 hour can make a big difference between life and death. I have a couple examples, obviously anecdotal, but still tell you examples of what I'm talking about. One would be Portia Gibbs, North Carolina. At 48, Portia suffered a heart attack 75 miles from the nearest emergency room. She later died while waiting for a helicopter to arrive that would have taken her over the state line to Virginia, where the closest hospital was located. If Portia's heart attack had occurred just 1 week earlier, Portia would have been transported to a hospital in Belhaven, North Carolina, just 30 miles away. Unfortunately, the facility in Belhaven had closed just 6 days before Portia's heart attack, citing insurmountable financial struggles, something we hear from hospitals across the country. Even a few hospitals in the state of Iowa have some financial troubles. Then there is the tragic story of 18-month-old Edith Gonzalez, who choked on a grape in her hometown, Center, Texas. Edith's frantic parents rushed her to their local hospital, Shelby Regional Medical Center, only to discover that it had closed just weeks earlier. By the time little Edith arrived at the next closest hospital, she had passed away. While we can't say with certainty that both Edith and Portia would have survived if their local hospitals had not closed, we know for sure that earlier people access care, the better their chances are of surviving. The term used for emergency medical practitioners about this period of time of roughly 1 hour, as they say it, that's the golden hour. The golden hour is the hour following a traumatic event when life-saving intervention, like that which can be provided in an emergency room, has the best chance of impacting survival. In other words, the longer a patient has to wait to receive emergency medical care, the lower their chances are of survival. Rural hospital closures mean patients have to travel longer distances to access emergency medical care. Ensuring that rural communities keep their emergency care resources could make the difference then between life and death. Rural hospital closures also extend beyond the loss of emergency services to include economic consequences for rural communities. Hospital closures can mean the death of a rural community. Approximately 62 million Americans live in rural America. Rural communities play an integral role in the economic stability of this country through their invaluable contributions of food production, manufacturing, and a lot of vital industries. In addition to supporting the medical needs of those who participate in rural industry, rural hospitals also serve as the single largest employer in most rural communities. The economic impact of closing a hospital, when no other hospital is closed, by those outcomes are very devastating. If we care about the physical and economic health of rural communities, we must make a change that will reverse the trend of accumulating rural hospital closures. iAdvantage Analytics compiled a report for the National Rural Health Association, which identified 283 additional hospitals at risk of closure based upon performance indicators that match those of these 53 hospitals already closed. So, Madam President, allow me to direct your attention to the map of the United States. This map depicts the approximate location of 53 of the 55 hospitals that have closed in the last 5 years. I would like to point out that between printing of this chart and this very day, 2 additional rural hospitals have closed. That alone is a clear indication of the problem that I'm trying to convey to my colleagues. Now imagine this same map here depicting 5 times the number of hospital closures that you see right here. 5 times the number of red dots. That's what's possible out there in the next few years. And then that's a fact of what will happen if we do not act to protect America's rural hospitals. Furthermore, the loss of those additional hospitals would not only impact local economies, but it would also result in a $10.6 billion loss in GDP. It must change, not only for the health of rural Americans, but also for the health and stability of our economy. Payment cuts to hospitals are one contributing factor to rural hospital closures. More significant, however, is the current Medicare payment structure that supports rural hospitals. Today, the Medicare payment structure for hospitals is focused on inpatient volume. Emergency rooms act as a loss leader, and income is primarily generated through inpatient stays. A RAND study published in 2013 found that the average cost of an inpatient stay is 10 times the cost of an emergency room visit. Researchers at the University of North Carolina found that many of the at-risk rural hospitals around the country have an average of 2 or fewer patients admitted to a hospital on any given day. These hospitals can have up to 25 inpatient beds. But if only 2 or fewer of those beds are filled every day, that's a utilization rate of 8% or less. So, instead of letting these facilities close because they don't have the needed inpatient volume to generate enough revenue, why not then let go of the underutilized inpatient services in favor of sustaining life-saving emergency care. So I get to what the REACH Act actually does. It provides a voluntary, emphasize voluntary, pathway for rural hospitals to eliminate their underutilized inpatient services and ensure residents have access to emergency medical care that saves lives. A key component of the bill that allows the rural emergency hospital model to function is a requirement that these facilities have protocols in place for the timely transfer of patients who require a higher level of care or inpatient admission. The value of the rural emergency hospitals in the case of a life-threatening emergency will be their ability to administer life-saving measures in order to stabilize a patient before they're transferred to a higher level of care. In addition to providing life-saving emergency care, rural emergency hospitals will have the flexibility to provide a wide array of outpatient services, including observation care, skilled nursing facility care, infusion services, hemodialysis, home health, hospice, nursing home care, population health, as well as telemedicine services. This list is not meant to be all-inclusive, but is just a sample of the outpatient services that rural emergency hospitals could provide to their respective communities. So the door is left open for rural emergency hospitals to design their outpatient services to match the needs of their communities. There are roughly 1,300 critical access hospitals in America, including 2 in my state of Iowa, the second most just behind the state of Kansas. I'm not suggesting that 1,300 critical access hospitals will become rural emergency hospitals. Some hospitals may never consider giving up their inpatient beds. Others may consider it in the future. But some critical access hospitals need this or something like it right now. The rural emergency hospital model, with its outpatient and emergency care services, will be good for the health of rural communities and our nation because of the critical care it will provide when and where rural Americans need it. When there is a farm accident in the afternoon or a heart attack in the middle of the night, that emergency room can be the difference between life and death. Medicare needs a payment policy that recognizes that simple fact. I look forward to continuing to work with my co-sponsor, Senator Gardner, other colleagues, and stakeholders in building a sustainable future for rural health care.